Welcome to the Part 1 question set 21. Let's get started. First question here, what are the Jones criteria for the diagnosis of acute rheumatic fever? So rheumatic fever is where you have an acute group A strep infection like strep throat, and then you have an immune reaction to that infection, and those antibodies cause all sorts of problems. And to make the diagnosis of acute rheumatic fever, you have to have evidence of a strep infection plus 2 major criteria or 1 major criteria plus 2 minor criteria. And the major criteria are what we call the Jones criteria. And it's great because we have a mnemonic, Jones, to help us remember this. So the J is for joints, and that's going to make us remember the polyarthritis that goes along with this. O is a little bit off. You kind of have to make the shape of a heart for the O, and that's going to stand for pancarditis inflammation. That's going to be of the endocardium, the myocardium, even the pericardium. N is for nodules. So these are the painless subcutaneous nodules, sometimes subcutaneous plaques. E is for erythema marginatum, which is sort of this ring-like rash that can appear and disappear relatively quickly. And S is for Sydenham chorea, which is so the coriform erratic movements, and they can happen in the face, the tongue, the upper limb, so a lot of erratic movements there. So those are the major criteria. Those are the Jones criteria. Don't get those mixed up with the minor criteria. So you need 2 of these major plus 1 minor, and the minor criteria are fever, arthralgias, elevated SED rate or CRP, prolonged PR interval on EKG. So those are pretty nonspecific, so they're less important for you to know, but you should definitely know those Jones criteria. Next question, what is the cause of hypertrophic cardiomyopathy? Well, it's caused by one of a variety of genetic mutations in at least 9 different gene segments, all of which encode the sarcomeric protein. So examples of mutated proteins include the beta-myosin heavy chain, the cardiac troponin T, alpha-tropomyosin, and myosin-binding protein C. Now, usually the inheritance pattern is autosomal dominant with variable penetrance. Now, these protein mutations result in myocyte hypertrophy and disarray, which leads to a massively hypertrophied left ventricle, which leads to decreased compliance, poor chamber filling, which leads to impaired diastolic filling and a reduction in stroke volume. Very important to understand the pathophysiology behind HOCM for step 1. Next. What is the mechanism of action of the following cholinergic agents? So first we have pralidoxime. So pralidoxime regenerates cholinesterase that's been inactivated by cholinesterase inhibitors like organophosphates. Neostigmine is an anti-cholinesterase, one of these cholinesterase inhibitors which keeps endogenous acetylcholine around longer. Because if your cholinesterase enzymes are inhibited, you are not going to be breaking down acetylcholine at the nerve terminal. Bethanechol is a direct cholinergic agonist. It actually agonizes the muscarinic receptors. Hexamethonium is a nicotinic acetylcholine receptor antagonist. Atropine is a muscarinic antagonist. It competes for the binding sites of the muscarinic acetylcholine receptors. Carbachol is another muscarinic agonist. Several of these drugs have chol in their name, just like acetylcholine. So carbachol, bethanechol, methacholine, all are muscarinic agonists. They have the same effect as acetylcholine. That's one way to remember that. Next, during fetal development, what structure traps the inferior poles of the kidney, resulting in a horseshoe kidney? Do patients with horseshoe kidneys have abnormal renal function? So the answer there is the inferior mesenteric artery. But then, do patients with horseshoe kidneys have abnormal renal function? The answer is no. Next question. An adult trauma patient begins to experience shortness of breath on day 3 of his hospital stay. The patient had an open reduction internal fixation of a right femur fracture. You are concerned the patient's shortness of breath might be attributed to an embolus. What type of embolus is the patient at risk of getting? What are the different types of emboli? So this patient is at risk of a traditional thromboemboli because he's stuck in a bed, which can lead to blood stasis. Anytime you're not moving for long periods of time, then you increase that risk of blood clotting. He's also at a risk of a fat emboli because of long bone fractures and pelvic fractures. Those are going to increase the risk of that fat emboli. There's fat inside of bone marrow, and that can get into the veins. Or on another theory is that the fracture disrupts the overlying adipose tissue, which allows fat droplets then to get into the veins as well. So whenever you see a pulmonary embolus following a fracture, always think about that possibility of a fat embolus. So the second part of this question asks, what are the different types of emboli? So we just talked about the fat emboli. We also just mentioned about regular thrombi or thromboemboli, which is probably the most common. You can also get bacterial embolus or septic emboli, classically from a bacterial vegetation on a heart valve in infective endocarditis. You can inject an air bubble into a vein that could cause an air embolus. This can also occur with decompression sickness, or what we call the bends. Sometimes this can be as a complication of delivering of a baby, and a mom can develop what's called an amniotic fluid embolus, and that's the other one that can lead to major problems as well. Next question. A 25-year-old man is evaluated in the clinic for red, swollen, painful right wrist and left knee joint. During the exam, the patient brags about his sexual conquest, because that's what all patients do. What sexually transmitted organism can cause osteomyelitis as well as this patient's septic arthritis? So the answer is Neisseria gonorrhea. So it's one of the most common causes of septic arthritis in a young, otherwise healthy person who is sexually active. Next, what is the site of action of each of the following diuretics? So first we have thiazide diuretics. They act in the distal convoluted tubule. Loop diuretics act in the ascending loop of Henle. Carbonic anhydrase inhibitors act in the proximal convoluted tubule. Osmotic diuretics work in a couple of sites. They work in the proximal convoluted tubule primarily, but also in the thin descending limb of the loop of Henle. And the osmotic diuretic mannitol also has an effect on urine in the collecting duct as well. And then finally here we have the potassium-sparing diuretics. They act in the collecting tubules. Next question. How can a skull fracture at the base of the brain lead to a pulsating exophthalmos? So the skull fracture will lead to a torn ICA in the cavernous sinus, which will lead to high blood pressure in the sinus, which will then lead to blood filling that ophthalmic vein and orbital tissue, and then you therefore get the exophthalmos, which then pulsates. Next, the different hereditary hyperbilirubinemias can all present with jaundice and scleral icterus. What is the underlying cause in the following hyperbilirubinemias, and what form of bilirubin is elevated in the serum in each disease? First, we have Gilbert syndrome, where you have mildly decreased UDP glucuronal transferase. So this is the enzyme that conjugates bilirubin. So it's conjugating bilirubin to glucuronate. So it's joining bilirubin to glucuronate, and that's that's the conjugating aspect of all this. So if you can't conjugate bilirubin, you're going to have unconjugated bilirubin in your blood. Crigler-Najjar syndrome type 1, much more severe deficiency in the same enzyme, so UDP glucuronal transferase. So again, you'll have even more unconjugated bilirubin. So Gilbert syndrome is just a tiny elevation in unconjugated bilirubin, and that's usually clinically insignificant most of the time. But with Crigler-Najjar type 1, you have high bilirubin and jaundice and even kernicterus. There's also a Crigler-Najjar type 2, which is much milder than type 1, much like Gilbert syndrome. And then Dubin-Johnson syndrome is a disorder where the hepatocytes can conjugate the bilirubin, but they can't secrete that conjugated bilirubin into the bile. So here you see elevated conjugated bilirubin in the blood. This is also mainly a benign condition. Next question. In patients with a prolactinoma, what pharmacologic agent can be used to inhibit the release of prolactin? And then in normal physiology, how is prolactin secretion regulated? So the answer here is bromocriptine, and that is going to inhibit the release of prolactin. It is a D2 agonist and can be used in the treatment of a prolactinoma. In normal physiology, how is a prolactin secretion regulated? Well, prolactin is secreted by the anterior pituitary, and it is tonically inhibited by dopamine from the hypothalamus. So TRH, pregnancy, OCPs, most estrogens increase prolactin. Antipsychotic medications, most of which are dopamine antagonists, will stimulate prolactin secretion as well, so remember that. So prolactin inhibits its own secretion by increasing dopamine production, and then that gets released by the hypothalamus and then negatively feedbacks back on itself. All right, guys, so that brings us to the end of set number 21. I hope you learned something. I'll see you next time.